Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to a new year and a new edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to be and live on this land. As well, we recognize that our webinar participants are attending this session from traditional Indigenous lands across what we now call Canada. Please take a moment to make your own land acknowledgement to the peoples of those lands, thereby actively participating in reconciliation as we navigate our time in this session, learning and supporting each other. Today, we're delighted to partner with the Canadian Institutes of Health Research to bring you mental health and substance use in children, youth, and families during COVID-19. The findings from 2 CIHR-funded knowledge syntheses. Just a reminder that we record all our webinars, and as mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and we'll pose the questions to our speakers at the end of each of the 2 parts of this session. I'd like to introduce our speakers for today. Dr. Salima Meherali is an assistant professor in the University of Alberta's Faculty of Nursing. She's an early career researcher with a research program with 3 areas of inquiry: immigrant, adolescent, and youth in Canada, mental health and sexual and reproductive health and rights of immigrant youth in Canada and in the developing world. Dr. Katie Birnie is a clinical psychologist and assistant professor in the Department of Anesthesiology, Perioperative, and Pain Medicine at the University of Calgary, where she leads Partnering for Pain, a patient-oriented research program that integrates patient and family partnership together with multi-stakeholder engagement to improve the prevention, assessment, and management of pain experienced by children and their families. She's also a medical psychologist in the Vi Riddell Children's Pain and Rehabilitation Program at Alberta Children's Hospital, as well as the Assistant Scientific Director of Solutions for Kids in Pain, a national knowledge mobilization network to improve children's pain management. And Justina Marianayagam is a medical student and has lived experience with chronic pain. Justina was appointed by Health Canada to the Canadian Pain Task Force to help address chronic pain for all Canadians. It is my pleasure to pass the mic to Salima.
Thank you, Paula, and thank you so much for giving the opportunity to present the findings of this knowledge synthesis study. First, I would like to thank CIHR for funding this study and University of Adelaide to collaborate in this research. I also respectfully acknowledge that the University of Alberta is located on Treaty 6 territory and respect the histories, languages, and culture of First Nation, Métis, Inuit, and all First People of Canada, whose presence continue to enrich our vibrant community. The knowledge and experiences of people of these nations are connected to the land, which I honor and respect. So today, presentation, I will discuss the impact of pandemic on children and adolescents' mental health and present the findings of rapid systematic review. As we all know that COVID-19 has impacted the lives of people around the world, including children and adolescents. Although the number of children and adolescents affected by the disease is small, and most of the affected children show only mild symptoms. However, the disease and the containment measures such as social distancing, school closure, isolation have negatively impacted the mental health and well-being of children and adolescents. Younger children are at great risk as high level of stress and isolation can affect brain development with long-term consequences. Some recent studies have shown that crisis events like pandemic negatively impact the psychological well-being of children and adolescents. Anxiety, depression, disturbance in sleep and appetite, as well as impairment in social interactions are the most common presentations. As the pandemic continues, it is important to monitor the impact on children and adolescents' mental health status and how to help them to improve their mental health outcomes in the time of current and future pandemic. The aim of this knowledge synthesis study was to identify and evaluate the impact of pandemic on children and adolescents' mental health, to evaluate the effectiveness of different interventions employed during previous and current pandemic to promote children and adolescents' mental health, and identify knowledge gaps in those contexts. This rapid review aims to provide guidance and offer recommendations to public health and policy makers related to applicability or transferability of strategies and interventions to improve mental health outcomes among children and adolescents in current and future pandemic context. We conducted a rapid review to provide timely evidence synthesis to inform urgent healthcare policy decision making. This review was conducted over a 1-month time frame with monthly updates provided from July to November 2020. This review was conducted according to the preferred reporting items of systematic review and meta-analysis guidelines. A comprehensive search strategy was executed by a trained research librarian on 8 major databases. We also searched for non-indexed database, including Google Scholar and preprint databases. To identify any missing papers, we also hand-searched the bibliography of all included studies and all relevant systematic reviews. This systematic review was informed by PICO framework. We only included studies that are conducted on school-age children and adolescents aged 5 to 19 years living in low, middle, or high-income countries. Interventions that are implemented to improve mental health outcomes of children and adolescents during current and previous pandemic or epidemics. For comparison, we included intervention versus no intervention studies. Primary outcomes include rate of anxiety and depression. Secondary outcomes include fear of infection, frustration and boredom, fear of pandemic-related uncertainty, fear of running out of basic supplies and finances. We included experimental randomized and non-randomized controlled trials, observational studies with an internal comparison groups, and qualitative studies. We included studies that are conducted on any recent COVID-19 or past pandemics. We located 5,828 articles, of which only 18 articles met the inclusion criteria. The majority of the articles that were excluded pertained entirely to adults or university students over the age of 18 years. The methodological quality of quantitative and qualitative articles was assessed using the mixed method appraisal tool. The methodological quality of quantitative articles were moderate to weak. However, the qualitative and mixed method article was strong. We were not able to perform meta-analysis because of various heterogeneity in the papers, such as study design, type of pandemics, age group of participants, and outcomes reported. Therefore, we synthesize our findings based on the type of pandemic, outcomes reported, and type of studies. We organized our findings based upon our outcome of interest, that is, impact of pandemic or epidemic on children and adolescents' mental health, the impact of control measures on children and adolescents' mental health, impact of pandemic or epidemic-related stigma on mental health, and effectiveness of different interventions employed during the previous and current pandemic to promote children and adolescents' mental health. 16 out of 18 studies examined the impact of pandemic on children and adolescents' mental health. The majority of studies use cross-sectional online survey to evaluate the impact of pandemic on children and adolescents' mental health. The most reported outcomes in these studies were the negative impact of pandemic or epidemic on psychological health, which was measured as anxiety, depression, fear, stigma, and post-traumatic stress symptoms. These studies reported that pandemics may cause stress, worry, helplessness, and also social and risky behavioral problems among children and adolescents, like, for example, substance abuse, suicide, relationship problems, academic issues, absenteeism from work, etc. Studies on the COVID-19 pandemic reported that the current pandemic has significantly affected the emotional and behavioral experience among children and adolescents. Depression and anxiety were found to be higher among children and adolescents during other and specifically during COVID-19 pandemic. Studies also reported that age, gender, knowledge about COVID-19, degree of worry about epidemiological infection, and confidence about overcoming the outbreak significantly influenced psychological status. Studies also reported that female adolescents showed a higher risk of depression and anxiety during COVID-19 than male adolescents. 7 studies reported that lifestyle transformations such as school closure, physical distancing, quarantine, isolation, and threat of being infected caused depression and anxiety disorder among children and adolescents. The psychological distress during includes fear, helplessness, worry, anxiety, insomnia, isolation, boredom, and sadness are more common in children who are quarantined. Post-traumatic stress disorder was also found among children who were quarantined during the H1N1 pandemic. Depression and loneliness was also significantly more prevalent in female adolescents who've been isolated and quarantined to contain the virus. Studies also reported that during the pandemic or epidemic, children and adolescents spend more time online or on social media than they do before the crisis, and found that stress and depression was strongest among adolescents who reported the highest social media use after the pandemic. Internet overuse may lead to mental or behavioral problems, causing poor performance in studies, decreased real life social interaction, neglecting personal life, relationship disorders, and mood dysfunctions. One qualitative study reported the psychological impact of stigma in children who were orphaned because of the Ebola epidemic. They were excluded from social interactions because of their association with Ebola. The prevailing fear and stigma of Ebola undermined the willingness of community members to help orphan children, and it had severe psychological repercussions for children orphaned by Ebola. The psychological effects of the stigma includes the feeling of being alone, frustration, worry or sadness, rejection and exclusion by family, friends, and communities. We found only 2 intervention studies to promote mental health of children and adolescents during previous epidemics. The study conducted by DeCosimo and colleagues implemented a community psychosocial program with an aim to improve mental health capacity of children aged 3 to 18 years during the Ebola epidemic. The interventions were given to children in settings where childhood trauma was prevalent. These interventions included expressive art therapies, yoga therapy, and play therapy to help children building healthy relationship and building a safe space for children to express themselves. This study found a statistically significant difference in the psychological stress symptoms over time before and after receiving the intervention. Another intervention study was conducted by Kamara and colleagues. They focused on the mental health of children and adolescents aged 10 to 17 years during the Ebola virus epidemic in Sierra Leone, when the psychiatric hospital was closed to admission to prevent disease transmission. To provide mental health services in Sierra Leone, the researchers established a nurse-led mental health psychosocial support services at one of the largest government hospitals in the country. Psychological first aid training was provided to nurses that focused on supporting those affected by Ebola virus. These nurses prescribe medications in collaboration with physicians, and children receive counseling and problem-solving approach to deal with their psychological suffering. The study found that training nurses to manage mental health issues is an effective measure to strengthen the local capacity. The finding of this knowledge synthesis study illustrate that pandemic or crisis situation could be associated with subsequent mental health problems in young people and that timely measures are currently warranted. With the objective of universal prevention and mental health promotion, it is very important that children and adolescents should be informed about the pandemic situations. With the aim to increase children awareness about pandemic, it is crucial for parents, teachers, and healthcare providers to communicate with young children in an age-appropriate manner by using simple terminologies about COVID-19. Children need to be given fact-based information about the health with the help of presentations and video materials provided by authorized international organizations such as WHO and UNICEF or government resources which have been tailor-made especially for children. Adolescents are expected to have better knowledge about COVID-19 compared to young children. Therefore, communication has to be more open and non-directive with them. Most of the adverse effects come from the school closure, isolation, limited physical activities, social distancing, and imposition of a restriction of liberty. Efforts should be made so that a consistent routine is followed by children and adolescents during school closure, with enough opportunities to play, read, rest, and engage in physical activities. Excessive internet use, like for example, internet surfing related to COVID-19 should be avoided as it results in anxiety. Similarly, excessive and irresponsible use of social media or internet gaming should be cautioned against. Negotiations with adolescents to limit their time and internet-based activities are recommended. More non-gadget related indoor activities and games are to be encouraged. Teachers have a role to play in the promotion of mental health among students. They can discuss what is well-being and how it is important for students. They can assist in teaching simple exercises, like for example, deep breathing, muscle relaxation, distraction, and positive self-talk. Virtual workshops can be conducted in which life skills related to coping in stress should be discussed by using more practical examples. There is a need to enhance children and adolescents' access to mental health services by using face-to-face as well as at digital platforms. Need for more virtual mental well-being programs in order to mitigate significant COVID-19 related mental health crisis in children and adolescents for the duration of the current crisis and beyond. The majority of the studies included in the review were based on online self-reports. The cross-sectional studies are useful in understanding the immediate or short-term impact apparent at a certain point of time. However, the limitation of these cross-sectional studies are that these studies cannot conclude about the long-term impact of pandemic. There is a pressing need for carrying out longitudinal and developmental studies. There is also need for evidence-based elaborative strategies and plan of action to cater the mental health needs of children and adolescents during the period of pandemic. Although the rate of COVID-19 infection among children and adolescents is low, the stress confronted by them poses their condition as highly vulnerable. This review identified that mental health problems are common among children and adolescents. However, very few studies have evaluated the impact of pandemics or crises on children and adolescents' mental health. The majority of the intervention-based studies were conducted on population 18 years and above. This review identified that mental health issues among children and adolescents can escalate during the pandemic. Therefore, it is important that parents, teachers, community health workers, and public health agencies should be informed and receive formal training to facilitate the early identification of children's psychological problems. We also believe that children's access to mental health services should be improved. Moreover, the post-pandemic surveillance of mental disorders and a longitudinal study among the children and adolescents population should be considered. These are the references I used in the presentation. Thank you so much.
Thank you, Salima. We've got a couple of questions in the question box for you. I'll just prompt our audience to type away as you think of those questions and get them ready. And I'll start. These were both anonymous posters. Were studies with children who had complex care needs, such as neurological, behavioral, or physical needs, considered? And particularly, as these children already face stressors and stigma related to their underlying condition?
No, in this review, we have only included the children and adolescents who have no underlying neurological or behavioral problems or any psychological problems, just the all normal kids without any underlying conditions are being included in this review.
And was there a difference studied or noted between rural and urban and even suburban populations?
No, we were not being able to identify because most of the cross-sectional studies have not reported that in which setting they have conducted this study, or like the surveys were conducted. They have not reported any difference between rural or urban children and adolescents' mental health issues.
And did you look at, or were there any indications that further study might be needed into sort of mental health and including PTSD among families of children who might have been affected?
Yes. Right. Yeah, we have identified that many of the studies are being conducted on the children and adolescents who are already suffering from some kind of mental health issues. And more focus was given on those children as compared to like normal children without any underlying condition. So it is very important to identify, because this time the pandemic was a very long for a very long time period, and during this pandemic, because of social distancing and especially with the school closure, it has really impacted the mental health of the children without any underlying conditions. So it is really needed that we have to conduct a longitudinal study to identify the impact of pandemic on mental health during the pandemic as well as after the pandemic as well.
Very good. That's the end of that set of Q&A, but if others think of questions for Salima as we move forward, please do type them in. And we'll now move to Katie and Justina.
Wonderful. Thank you so much. I'll just put up the slides here. It's a real pleasure to be here with you today and share information about our rapid knowledge synthesis related to virtual care solutions for youth and families during the COVID-19 pandemic. I'm particularly thrilled to be here with Justina, who's a patient partner on the project. So certainly, the COVID-19 pandemic is challenging. We know from some of the research that Dr. Meherali was presenting, as well as others, that certainly youth and families are at increased risk for exacerbation or new onset mental health symptoms during the COVID-19 pandemic. But there are also reports of increases in pain or somatic complaints, including things like stomach aches and headaches, which go quite closely, often, not always, but sometimes go closely hand in hand with mental health concerns and so on. So we're at kind of this time of the potential risk for new onset of chronic pain complaints in youth, as well as in close hand with increase in mental health issues and substance use problems. And I think it's really important for those who aren't familiar, chronic pain in youth is already a health emergency in Canada. So the prevalence of chronic pain is between 1 in 4 and 1 in 5 children who will deal with chronic pain before they reach adulthood. It costs billions of dollars to us from a societal perspective each year, and has an impact across all areas of life. So social functioning, school functioning, certainly mental health concerns. So youth with chronic pain are 2 to 3 times more likely to be dealing with a mental health concern as compared to their peers who don't deal with chronic pain. And it's not just a risk in childhood, it's a risk that continues into adulthood. So really this incredible stressor we're all dealing with is putting youth at risk now, but putting youth at risk for persistent pain, mental health, and substance misuse across their lifespan as well. And I'm just going to turn it over to Justina to share about her experience as well.
Hi, everyone. Hope you can hear me okay. My name is Justina Marianayagam. It seems so important. It got mentioned twice. I was like, oh, we're at 2 introductions. Awesome. So as mentioned, I'm a medical student right now in my 3rd year based in Kapuskasing, which is in rural Ontario. But most importantly, I'm a patient partner and a former pediatric patient who lived with chronic pain, and I still now live with it as a young adult. And so I think it's been really difficult as a patient to now, with the pandemic and having to manage all these different scenarios. One particularly is when the pandemic hit in March, was 2 weeks after I started on a new medication. And, there was that fear and the difficulty of like not being able to go in to see my physician in person for like physical exams, and I was experiencing some like pretty negative side effects. And I was both worried just with the anxiety of being exposed in hospital unnecessarily, and even for blood work, things like that. So just overall management, I think, from a patient perspective was difficult, and it continues to be difficult. A lot of services like chronic pain management have been put on the back burner. A lot of patients are not able to gather in person, and especially from a pediatric perspective, me myself, like when I was at Sick Kids, it was that face-to-face and it was that in-person interaction with other patients that really helped me throughout my journey. So can't really imagine what other kids going through that from 18 and younger are going through right now.
Thanks, Justina. And certainly, I think some of the issues you're talking about, we've heard in some of our work, even before the COVID-19 pandemic started, that improving that access and delivery of evidence-based treatments to support youth, as well as improving coordination of care with that view to reduce disparities, was identified in national patient-oriented research priority setting for managing chronic pain for children and adolescents and their families in Canada. And I think we all know, it's no surprise, this has shown up in kind of our conversations around chronic pain in youth, but across all areas of mental health and healthcare, that virtual care was a necessity before pandemic, but it really is a necessity now. And regardless of what our new normal or how we talk about that moving forward, it will continue to play a much larger role in healthcare delivery in Canada as we move forward. So our goal in our rapid knowledge synthesis project was to really take some action together on these priorities. We wanted to identify recommendations for virtual care best practices to support youth with pain, mental health, and substance use problems in their families. And then we wanted to map those out using a knowledge synthesis methodology called evidence and gap map to really guide multi-stakeholders, so patients and families, health professionals, healthcare decision makers, and policymakers regarding virtual care for youth and what was available and what could be recommended, and where are there gaps for where we need to put more priorities. And through this work, we partnered with Solutions for Kids in Pain, an organization called Pain BC, and a Pan-Canadian Health Canada funded organization called the Continuum Foundation for Healthcare Improvement. The other part we integrated throughout this was patient engagement. And I am really a proponent that and believer that patient partnership is really a game changer in how we conduct and share about health research. So through this, we had a number of patient and parent partners. Justina is one of them. But in addition to Justina, we also had a parent of 2 youth with chronic pain and another teenager who lives with chronic pain herself, who were considered equal members of our research team and really involved in co-producing our methods and dissemination products. We also had an additional patient and parent advisory group that I'll tell you a little bit about as we move along. But that was an additional 7 youth and 4 parents and caregivers from across the country who met with us on 2 occasions last August virtually to provide some guidance around how we mapped out our evidence and gap map and what were really important factors to document or to capture about the virtual care solutions that exist. And then in addition, we also had another youth with chronic pain and 3 parents and caregivers who participated as part of a merit review panel for innovations in virtual care that were integrated into our knowledge synthesis. So I'll share about that as we go through. But you can see we really integrated in a spectrum of engagement a number of different youth and parents for whom this work is directly relevant today. So our first phase was to map out best practices for virtual care solutions. So we wanted to look at things like apps, websites, therapy over video call, really a broad definition of what we mean by virtual care. And what we did is we went to the scientific literature. We identified from that 16 articles that met eligibility criteria. And these really needed to be peer-reviewed scientific English language publications that really spoke to recommendations, guidelines, best practices around virtual care for chronic pain and mental health or substance use issues in children. And then we mapped out, kind of using meta-ethnography techniques, synthesized themes kind of from across these papers. We did not find already existing clinical practice guidelines around virtual care for chronic pain in youth. So first of all, we identified from these papers that we need to better leverage virtual care. It's considered generally acceptable, reasonable, and effective. It has the potential to ensure better access to care, particularly in rural and remote areas. Although, of course, as we've learned throughout and seen throughout the pandemic, certainly exacerbations in social inequities, where even access to internet remotely can be challenging. And that also virtual care is generally underutilized, especially for things like real-time symptom assessment or psychological treatment. We identified some best practices for when we implement virtual care. It should be freely available across all technologies, whether that's telephone app, websites, or video conference. In best cases, it includes some training, terms of use, and guidelines, both for health professionals, but also to support youth and families. That it needs to use secure infrastructure, such as being encrypted, password protected, having authorized access. We need to consider that the platform and use of it is developmentally appropriate. I think particularly relevant when we talk about pediatric populations there, that asking, a 3-year-old to sit in front of an hour-long video conference call with a multidisciplinary team is not going to be ideal. It must meet ethical standards of care, of course, and should be transparent in communication. So some virtual care can look like it's coming from a therapist, but the messaging is actually computer generated. So we need to be really transparent about that. When we're thinking about how we select best platforms for virtual care, they need to be user-friendly and acceptable to youth and families. They have to be backed by some sort of science. They should involve, ideally, youth, families, and health professionals in their development. So the end user is something called user-centered design. Ideally, they're also individualized or customizable, or can be tailored in some way to the individual patient's need or goals. In terms of chronic pain care, they need to touch on what constitutes comprehensive pain management. So from an evidence base, that includes both being able to integrate pharmacological, psychological, and physical strategies in some capacity. Otherwise, virtual care alone is really insufficient in providing evidence-based care. It needs to include multimedia content, so videos, text, images, voice to audio, lots of different things, which ties also to meeting accessibility standards. And it should be able to integrate social and peer support. But we also identified people talking about a lot of gaps. So there were no standardized practice guidelines for implementation, and critically also evaluation of virtual care. We need to know that it meets all of these criteria. Ideally, we also have evidence showing its effectiveness for all concerns identified by youth and families, not just some. That we need to have knowledge about its limitations and suitability for all aspects of care. So lots of conversations about how to do physical exams. What are the limitations around that virtually? Needs to consider potential harms and the impact or potential impact on the therapeutic relationship. Certainly differences if people have had a pre-existing relationship with health professionals in person and then shifted to virtual care versus meeting for the first time virtually and only virtually. We need strategies to enhance engagement, continued engagement, particularly with things such as apps or other self-driven virtual care solutions. And we need to talk about how this integrates into clinical care pathways. When virtual, when face-to-face, how do these things intersect? And how do we make sure that virtual care is directly being integrated or able to be directly integrated into the electronic medical record? So that was the first phase of our project. We also wanted to map kind of our virtual care solutions that we identified in stage 2 across something called a stepped care continuum. And the stepped care continuum, you can see, goes up in gradual steps. Some models have 5 to 9 kind of steps, and they increase in the time commitment and resources that are required as you move further up in the stepped care continuum. And the idea is that you're trying to match the level of treatment to the level of need, and that things that are more self-guided are less resource intensive, less time commitment, less health professional involvement or no health professional involvement can reach more people. And then as needed, people can be stepped up to more intensive care up to the top, which is really that specialist real-time kind of tertiary interdisciplinary care. These are models pre-pandemic that have been promoted and adapted by the Mental Health Commission of Canada. Recently, also in our Health Canada's Canadian Pain Task Force, talked about as a relevant model for chronic pain care. But also, if you look in the literature, following previous natural disasters, such as widespread forest fires in Australia, and the impact of those on mental health care, step care models have also been recommended for mental health care approaches for youth in response to natural disasters. So what we did for this knowledge synthesis is we looked at the scientific peer-reviewed literature. Now this time specifically looking at innovations themselves, so studies that were evaluating virtual care solutions. We also did a search of gray literature, so looking at the app stores and websites. And then we did a call for emerging innovations for new virtual care solutions for this population in partnership with SKIP and the Continuum Foundation for Healthcare Improvement. This is what this is our kind of Prisma flow diagram that shows what we identified. But the important part is just to identify that we had 185 records that are included in this evidence and gap map that come from each of these sources. So some scientific literature, some apps, some websites, and some new emerging innovations. And we did actually, similar to Dr. Meherali, we also used the MAT to assess scientific quality of each of these records and the evidence and gap map to give us an estimate for when we create it. So I'm just going to show you a brief video about the project to introduce the evidence and gap map itself.
Right now, 1 in 5 children are living with chronic pain. That pain comes in many forms, like headaches, stomach aches, and muscle pain, and is one of the most common symptoms experienced by youth during stressful events, like the COVID-19 pandemic. Treating these symptoms now is key to preventing a lifetime of chronic pain, mental health, and substance use problems. Families already had trouble accessing care, and the pandemic has only made it more difficult for children to get the care they need at traditional health centers. There has never been a more urgent time to understand and use virtual care. Virtual care offers the opportunity to connect with a health professional or peer support group via phone, text, video conferencing, and other apps right from the comfort of your own home. And while there is work to do to improve internet speeds and connections in rural communities, virtual care makes healthcare more accessible for so many more people. This style of care is new, but we already know it works. Things are changing every day, and we're in a constant state of information overload. But good, reliable information is available from trustworthy sources across the country and around the world. We want to make it easy for people to find and use that information now. So we created this evidence and gap map as a centralized one-stop shop for patients, parents, health professionals, and policymakers. The map combines all of the evidence on virtual care interventions from around the world and displays it in a way that quickly highlights what we know and what we don't know. Interventions can be filtered by the quality of the evidence or what technology they use. You can see what's new, what tools each intervention offers, and who it's designed for. This map is a guiding light for people working to establish and pursue innovative ways to help youth living with chronic pain today, in the hopes they can get back to living life pain-free. This is new, it is working, and we need it now more than ever. To explore the virtual care evidence and gap map, visit partneringforpain.com.
So this is the static kind of evidence and gap map. So it gives you a sense, as you can see, across different levels of stepped care, and then the different categories across the top about what we needed to code each virtual care solution for were identified by that advisory group of youth and parents. And I want to show you what this actually looks like in real time, because I think it's much more impactful to see the evidence and gap map in real life. So this is what it looks like through the link on our project website. And you can see each of these categories, so components of virtual care solutions, can blow out, where you can look at, which virtual care solutions track for pain, anxiety, mood, physical functioning, sleep, and so on. We also look at different aspects of medication, such as medication tracking, side effects, different psychological strategies that are integrated across the virtual care solutions, physical and lifestyle strategies, social and family components, opportunities within it for health professional communication, integration of school resources, emergency crisis strategies, aspects related to user experience. So is there information or data that speaks from the patient and family perspective about functionality, usability, accessibility, customizability, and so on? Can it be integrated within the health record? Who's the intended user? So is it children, adolescents, individual group, or the health professional? And then type of pain or diagnosis. So mixed chronic pain conditions, and then other specific chronic painful conditions such as arthritis or rheumatological, headache, migraine, kids with neurodevelopmental disorders, sickle cell disease, and so on. And each of these boxes or circles, represents the larger size represents more records in the evidence and gap map, and the different colors represent the quality of the scientific evidence. And then you can filter. So if I'm interested in particularly only looking at high levels of scientific evidence using smartphone devices, I can update and the evidence and gap map will adjust. And then I can click on these and see there's 5 high quality records, and then information will pop out from the right-hand side with an abstract about that record, links to where it is, where it's published, or where you can find it on the App Store. So it's quite interactive to suit kind of what information you're looking for, while also clearly highlighting gaps where there is no information. So what did we learn? Most virtual care solutions are widely applicable to youth with any chronic pain condition. There's more than 100 self-guided apps and websites. So that level 1 of stepped care, self-guided for the general population. Apps report the most customizability, and psychological strategies are numerous and provide high quality evidence. But there's a lot of gaps. So most apps and websites lack scientific evidence. There's lacking of virtual care solutions at higher levels of stepped care. So ongoing individuals, health professional support, or tertiary virtual care. It rarely integrated information into the electronic medical record or had the ability to communicate with health professionals. Only a moderate number had engaged parents with very little peer or sibling support. And a general dearth of virtual care solutions that address some areas that were really important as identified by our youth and parent advisory group, including medication side effects, medication tracking, sleep, diet, substance use, school resources, information for teachers, and how to deal with acute pain flares or crises such as suicidality, and very few, less than 5%, addressed web content accessibility. We also wanted to respond to policymakers. So as part of our knowledge mobilization in our grant, we created a policy brief in English and in French, which linked to all of the information and a one-pager about the best practices for virtual care. And really also tied it to the most recent report from the Canadian Pain Task Force in October of 2020 that was published. So we're able to share kind of this evidence and gap map and best practice resources in a way that policymakers and decision makers can act on right away in areas they've also identified as relevant. We've taken some next steps with our project through an additional knowledge mobilization grant from the Ontario SPORE Support Unit in partnership with others, where we're taking the findings from our phase 1, so those best practices for virtual care, and doing a series of community engagement with communities that are particularly disadvantaged and are more likely to experience inequities in pain and mental health care. And that includes Black youth living with sickle cell disease, Indigenous youth living with chronic pain in their families, and children, youth with medical complexities in their families as well, for which we know the different modifications or considerations may be particularly critical. So that's being done in partnership with a number of organizations. And then this work is also feeding into a larger COVID operating grant led by Dr. Jennifer Stinson from Sick Kids and Dr. Melanie Knoll, who were co-investigators on this project, where they're looking at the impact of the COVID pandemic on youth living with pain and care throughout the country, but also have efforts through there to create a centralized national access to virtual stepped care for pain in youth through partnership with Wellness Together Canada and development of a kids pain portal. So virtual care solutions that have good evidence will be identified from the evidence and gap map to integrate into that pain portal. And then I'll turn it over to Justina for any last words about being part of this project, and then look forward to taking questions.
Hi, everyone. Yeah. Thanks, Katie. That was great. It's really nice to see all the hard work you put in. And I think I just really like reflecting on this whole hour and hearing all this. I think what's really important to note is this is so new. Like, this is so like new for patients, right? I can't remember a time in my life, my lifetime, where I wouldn't have access to a physician as easy as just going right into my appointments to see them, right? So these barriers, it's very hard to understand as someone in their 20s, let alone someone in their teens or younger than that. So all this research that we're doing to look at like what can we do now to help patients in this situation is not only going to, help this generation now, but like generations to come. If there is like, hopefully not like a 2.0 version of COVID, or at least like understanding what helped them in like their most vulnerable position and how can help them further. So I just wanted to touch on like what it's been like to be a patient partner. First of all, like anybody who's on the call who has not ever worked with patients or family care members on their research or even within their administrative work, I really do recommend it. It's so like humbling and great to be able to look back just on like less than 5-6 years ago. I was like bedridden at Sick Kids to now being able to advocate and work on research projects like this to help children and help youth who are in my position now, like when pretty much in my darkest time. Katie, Dr. Birnie has been great, and everybody else, to make sure that you accommodate to patient, partner, and family member needs. Like last night, Dr. Birnie actually called me like at 9 p.m. to review for this presentation because she knew that I was on call, or now that accommodating my needs now as a student, or if, she knows I'm having a bad pain day, and I'll let her know, and I feel comfortable letting her know that. We'll accommodate another timing. So making sure that you are listening to your patient partner needs is very important when you're collaborating. We also have been able to co-publish on things as well. So bringing and rebalancing the level is when you bring patient partner and family partners in, they are also co-investigators on your work. Like we are, some might not have like a PhD next to our names or anything like that. However, the value that a patient and a family member can bring to your work, it can move mountains, in my opinion. I think that deserves also the ability to be able to co-author on that and be able to showcase that and feel as valued means a lot to us. And I think another thing to note with patient and virtual care is just sitting on your computer all day, things like that, having like phone meetings instead of a video call might be good. Offering patients to turn their video off if they don't want to because they're pacing around their home. So just things like that. And I'm open to any other questions that people have, or if Katie wants to comment on that.
Sure. I was just looking, I think you were touching on this, Justina, a comment just about the specific role that patient partners had in the project and how kind of your and others' insights and lived experience contributed to the data that was generated. So I'm going to speak a little bit more to that too, in addition to what you've talked about. But I think, when we look at the evidence in gap map, how we identified what should the columns be, what should they be called, what do we need to actually capture? If I had not engaged patient and youth with living with pain and families as part of this, I would have looked to the literature and looked at, there are existing guidelines for what outcomes should be, should be included in clinical trials, for example, looking at interventions for chronic pain. And that would have been my go-to kind of as a scientist. And those guidelines are actually being revamped now. They're about 10 to 15 years old because they've been criticized because patients and families were not involved in identifying what outcomes mattered to assess whether interventions were effective. And if you compare what shows up in our evidence and gap map with what's part of those recommended guidelines in terms of outcomes, there is new things. There are things there, especially some of the things I mentioned around medication tracking, diet, school, information around acute pain flares and other crises. There are a number of topics, peers that just wouldn't have been included. And I think when we're doing a knowledge synthesis like this, and also pointing out, here's where we have quality information we can act on now. It's also really important to identify for researchers, for health funders, such as CIHR and others to say, or health professionals to say, here's where we don't have information, but people who are living with this every day want to know. So it helps to drive not only the decisions we make now based on available evidence, but how we direct where we create new evidence to respond to that. I'll just also add the patient and partners were really critical in our knowledge mobilization efforts, which was a big part of this this grant call as well, and getting this information out quickly. We created a one-pager synthesizing the best practices. Our patient partners, such as Justina and others, created comments on the layout, how things were worded, what it should look like. Also the graphics we have around it, we want those to be inclusive. Advice on the video that introduces it. So part of the being engaged in the script, the language, making sure that was accessible, but also the imagery within that. So if you noticed, there are multiple images of some more visible than others in terms of disability, for example, and disability not just amongst patients, but also the health professionals delivering virtual care. And also issues talking about rural access. So Justina grew up in Yellowknife, and and also, as she mentioned, is working and living rurally in Northern Ontario. And so the perspective about what is the impact of virtual care, what are the barriers and challenges as well as advantages of virtual care for families that live in rural and remote areas, or health professionals that might be delivering care in those contexts, was critically helpful as well. And then in my experience, when you, as a health professional and as a researcher, when we go to share this information with policymakers, in my experience, the best is the combination. The best support we can provide as researchers is to show up with the evidence and share it in a way that's accessible. But the real impact that bends the ear of those in decision-making capacities is the voice of lived experience. But when that's also backed by science, they're even more empowered and enabled, armed to make change. And then people with lived experience also feel supported, in being able to do so. So I don't know, Justina, if you want to add more to that specifically, but.
Yeah, well, just one point is that I'm always learning as a patient partner too. You recognize that, my condition is very specific circumstances, being from an immigrant family, but then I'm also learning from other patient partners about like what it's like to be a mom living with a child with complex needs and stuff like that, which really just opens up your mind in general as to like how patient needs are so diverse.
Paula, I saw there was one more question that maybe Dr. Meherali was going to answer, so we're happy to finish if there is something more she wants to add to.
Sure. The question that was posted for Dr. Meherali was, where were the studies able to account for factors that might influence children and young people to use the internet, including pre-existing symptoms?
Studies have not specifically reported about the impact of internet use among the children who have pre-existing symptoms. However, they have reported that overuse of internet lead to behavioral problems, poor performance in the studies, decreased real life social interaction, neglecting their personal lives, relationship disorders, and mood dysfunctions among the children and adolescents who are overusing the internet during the pandemic or any previous epidemics.
Thank you. For Justina and Katie, there's a lot of work being done in app development across a whole spectrum of issues. Any advice for app developers or those interested in developing an app around how to do it properly?
For sure. I think the biggest kind of singular advice and very brief is to engage the end users from the beginning for who you think the app is going to be used for. There are a lot of systematic reviews and looking at apps, both in supporting pain in children, but also mental health symptoms in children and so on. And if you look at how much apps are used after they're initially downloaded, it drops off very quickly and quite dramatically. And so there are a lot of apps out there that haven't been designed with people who use them, and people stop using them very quickly. So they're really not that helpful over time. As well, they're often not developed based on scientific evidence or have any sort of evaluation integrated within it. So I think there's a bridge there too, because we also know from some really interesting research that there are some apps that are created from a research standpoint that then are not made publicly accessible and readily available. So although they're very well designed and evidence-based, they don't actually get out to widespread use. So I think that partnership approach, and then also using like a user-centered design, are two kind of really good takeaways in terms of app development.
And will this app be available free of charge to folks, or do you plan on costing it?
Yeah,
yes.
they certainly should be. And I think that came from our recommendations from a virtual care perspective, is that cost to using virtual care shouldn't be the barrier to do so. So especially for apps that are publicly funded in development, obviously should be freely available.
Wonderful. Well, thank you all. That seems to be the end of our time together. Thank you, Salima, Katie, and Justina for sharing your time and expertise with us. Thanks to all our members and other attendees for spending this time with us as well. We hope you depart with some practical knowledge to bring back to your organization. You can join us again on January 20th at 11 a.m. Eastern, when we are partnering with CIHR once again to bring you Caregiver and Family Mental Health and COVID-19, a focus on autism spectrum disorder and eating disorders. On January 26th and 27th, Children's Healthcare Canada is pleased to host the first Canadian Transitions pop-up event. Please visit our website at childrenshealthcarecanada.ca for more information or to register. And it's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Katie, Justina, and Salima for this presentation, and to CIHR for supporting our webinar program. And hopefully we'll see many of you back here next week. Bye, everyone.